Right, so hi guys, welcome to the Finals Crash Course series. And today we are doing Renal Medicine Part 2, which is going to be taught by Michelle here. So just a disclaimer that everything, all the information that we have is gathered from various resources. There's a reference list at the end, and this is just to supplement your learning, and you should also refer back to your university notes as well. In the bottom left corner is our email if you have any questions, and in the top right corner is our QR code for our Instagram page if you want to scan and follow. So I'll hand over to Michelle now.
Thank you. Okay, so like I said, my name is Michelle, and I'm currently in F2. Today we're going to be focusing on acute kidney injuries and chronic kidney disease, so AKI and CKDs. Like Ashwini said, just a quick disclaimer, I've used a range of resources to kind of compile these slides, but there's a complete list of all the resources at the end, just if you want to go and refer back to them to get some more information. Okay, so first things first, let's start with acute kidney injuries, or AKIs. What are the aims of this talk? So hopefully you'll be able to understand the definition of an AKI, learn about the causes and risk factors for AKIs, the assessment and potential investigations when considering an AKI, and understanding the management of AKIs. So, what is an AKI? Basically, it's a clinical syndrome that has been, according to NICE, is defined as a sudden decline in renal excretory function over hours or days that can result in failure to maintain fluid, electrolytes, and acid-base balance. What do we usually look at? So that is basically serum creatinine or the urine output, and that kind of defines the criteria of what stage AKI that you've got. Why is it relevant? Well, the NHSC estimated that about 1 in 5 emergency hospital admissions are actually associated with AKIs in the UK. So that was in 2014. It prolongs inpatient care, and it can actually contribute to 100,000 deaths in secondary care, so in hospital settings. So it is very relevant to know about, not only for finals, but also in the real world. So I mentioned creatinine and urine output. So they are the hallmarks of diagnosing AKIs. So this is the table. It's adapted from NICE guidelines, and AKIs can basically be divided into 3 stages, 1 being a mild AKI, I guess, and 3 being a more severe AKI. So it's a bit clunky, but you can look at what stage AKI is based on whether there's a creatinine rise, so an absolute number of more than 26 micromoles in 48 hours, or you can look at it as a percentage from their baseline if you've got one. And that would be within 7 days, or like I said, urine output. So if someone's got reduced urine output, that can put them into an AKI, even if they might not have the creatinine rise that I just mentioned. In the second one, you don't actually use an absolute value. So it's you look at the percentage rise from a baseline or a reduction in urine output. And then 3 is a rise over 200% in creatinine, or like I said here, the acute values. The absolute values of a creatinine rise. Okay, and mainly if someone is anuric, so does not produce urine at all, that's a very severe sign, and that's a stage 3 AKI as well. Okay, so I mean, for finals, it's worth knowing this, but often in the in the real world, there'll often be lab biochemistry notifications to tell you what stage it is, but these are the ones according to NICE guidelines. Okay. So moving on to causes of AKIs, they can be divided into 3 sections. So there's pre-renal, renal, and post-renal. Pre-renal, so that's things like hypovolemia. So the kidneys aren't getting enough fluid, not getting enough blood. So that's blood loss if there's a trauma, GI loss such as diarrhea and vomiting, or sepsis. Other things like reduced cardiac output, so someone who's got heart failure. Drugs that reduce the blood pressure, circulating volume, or renal blood flow. So things like ACE inhibitors or ARBs can do that. Renal or intrinsic causes, so That's things like toxins or nephrotoxic drugs. So NSAIDs are common, or iodine contrast after a CT scan, for example. Vascular causes, so aortic dissections that can affect the renal arteries. And then things like glomerulonephritis, acute tubular necrosis, or rhabdomyolysis as well, and interstitial nephritis. These are less common and often dealt with by the specialists, but also important to know. And then finally, post-renal, that's things like obstruction. So whether it's prostate problems like BPH or catheter blocks, renal stones, anything like that can cause post-renal AKIs. So it's quite good to remember in that way, how to get an AKI in the pre-renal, renal, and post-renal. Okay. So risk factors, who's more likely to develop an AKI? So age, tends to be more than 65 or above. Someone who's had a previous AKI, they're at higher risk. If they've already got kidney disease, so chronic kidney disease, if they've got known symptoms or a history of urological obstruction or things that might cause it, so like I said, BPH or prostate problems, if that kind of worsens, they're higher risk of having an AKI. People with chronic conditions such as diabetes or heart failure, neurological conditions or cognitive impairment, disabilities, certain disabilities that might be due to reduced oral intake, sepsis, and that kind of links nicely with the next thing: hypovolemia, hypertension, dehydration, or reduced oral intake, oliguria as well. Okay, specific medications I mentioned earlier in the causes, so NSAIDs, ACE inhibitors, ARBs, diuretics, some antibiotics as well. Contrast exposure can also cause AKIs. Individuals with cancer, or actually receiving treatment for cancer, so I guess that links in with specific medications, they can affect the kidney function. People who are immunocompromised or immunosuppressed are higher risk of having AKIs. And if you've ingested certain toxins or exposed to certain toxins, that puts you at risk as well. Moving on to assessing. So if you've got someone in front of you who you think is either at risk of an AKI based on the brief history that you've got, or you already know they've got an AKI, you want to take a thorough history and do a proper clinical exam. So in the history, you'd want to look at things that might cause hypovolemia, so things like, have they been having diarrhea and vomiting? Is there any signs of severe infection? Are they febrile? Have they got any symptoms of urinary obstruction, any lower urinary tract symptoms, or are they known to have prostate problems, for example? How's their fluid intake been? Are they still passing the same amount of urine? Any other comorbidities, diabetes, high blood pressure, heart failure, anything like that? Have they got rashes, joint pain, epistaxis, or uveitis? So that's linked more to the kind of interstitial diseases, but it is worth asking. What medication have they been taking? Have they recently had some kind of injury and they've been taking lots of ibuprofen to get over that? If there are any falls, injuries, or overexertion, and that's more related to rhabdomyolysis, okay, and whether it might be the cause of why they've got an AKI. And then social situation, is there something that might be leading to have reduced oral intake, or again linked to the falls? Are they at risk of falls and things? Do they need planning into preventing that in the future as well? Okay, and then on the examination, you'd look at the JVP, blood pressure, heart rate, capillary refill time, skin turgor, mucous membrane. That's all part of your kind of fluid assessment and fluid status assessment. You look at whether they've got any peripheral edema, are they overloaded? Can you hear any crackles in their chest, the signs of pulmonary edema? And then you can feel for the bladder. Can you feel a palpable bladder? Do they sound like do they look like they're in retention? Can you feel any obvious masses? If they've got flank pain, is there pyelonephritis? Does it sound like they've got any stones? And then do they appear confused? And that's more either related to have they had to reduce oral intake recently due to another reason, to whether they're got an infection, they're off baseline, or is it a complication of the AKI, which is what I'll get to in a second. Okay, so how would you investigate, or what investigations would you consider? So it's quite a long list. It's not exhaustive. There are other things that you do based on clinical judgment, but because it's a kidney problem, you'd obviously start with a renal profile. So using these, you'd look at creatinine, you'd look at things like potassium, okay, the electrolytes. You'd do a VBG along with that as well. Look at the bicarb, look if there's any acidosis, is the pH okay, look at their glucose levels as well. You do a full blood count, check for infection, CRP with that as well. Liver function test, looking at albumin, right? Creatine kinase, that would be up in someone who's got rhabdomyolysis. So very important if someone's fallen, you don't know how long they've been on the floor for, or sometimes you get people who come in, they've been at the gym and they've overexerted themselves. You might want to consider that as well. You'd want to do urinalysis. So you start with a urine dip, check for any blood, protein, blood, have they got signs of renal colic, renal stones, leukocytes, nitrites, the signs of infection. You can then send it off for microscopy, to make sure they've got the appropriate antibiotics that they need, if that is the case. Osmolarity, if there's any kind of hyponatremia or anything like that, you want to look at that as well. Ultrasound and CTs, so these aren't always done first line. Well, actually, mostly they aren't done first line unless you're concerned for an obvious obstruction or renal stone. So that could then be considered if that's in their top differentials. And then biopsies could be considered if there's a high suspicion for intrinsic causes, but not acute tubular necrosis. That's something that would be guided by the renal team rather than yourself in the acute setting. Okay. So when to look out for an AKI? So when should you be worried or suspicious of someone having an AKI or at risk of developing one? So if someone's had nausea and vomiting, diarrhea, any other causes that lead to dehydration, if they've got a reduced urine output or sometimes change in urine colour, although that's not very sensitive, any signs of confusion, fatigue, drowsiness, any kind of acute illness with any of the things that I've just mentioned, and anyone who's got an illness, whatever, but with an acute component to it, so not a long-term condition, that have a background of CKD or any urological conditions, any new or onset or worsening of urological symptoms of a complication of UTI or a multisystem disease of, for example, ITP, you'd want to consider it and make sure, keep a close eye on them. And like I mentioned before, you'd get lab-based warnings for AKI. So they get automatically generated, so you have to kind of use your clinical judgment. But if it does come up, it's worth looking into that and digging it. Don't just kind of ignore it. Okay. So complications of AKI, quite a few, as you can see. So although the AKI is a concern in and of itself, there are also, complications that can arise from having an AKI. Main thing is electrolyte abnormalities. One that we often worry about is hyperkalemia. So kidneys excrete potassium. If the kidneys aren't working as normal, this might build up in the bloodstream. This then puts the patient at risk of things like cardiac arrhythmias or even cardiac arrest. But it's not the only electrolyte. You can have magnesium or phosphate imbalances as well. You could develop a metabolic acidosis. The kidneys, as you might know, play a very important role in acid-base balance through bicarbonate. So any disturbance in the normal functioning of the kidneys might lead to disturbance in the pH. So you might see that on the VBG, which is why it's important to do that. Fluid overload might develop as kidneys are crucial in the fluid management, in homeostasis. So if they're not able to excrete enough water, this might third space, especially in patients who are very unwell, for example, with sepsis. Next one to be aware of is uremia. Okay, so it can develop if the kidneys are not excreting enough urea, and kind of this can cause things like pericarditis, neuropathy, and encephalitis. So that's why I mentioned earlier to look at whether someone's confused in your assessment, because it might be a kind of complication of the AKI itself. If someone's got CKD, someone's got an AKI, it puts them at higher risk of developing CKD in the future. But we'll come back to that in the second part of this talk. If someone has CKD, they'd be at risk of developing end-stage renal disease, so kind of progression of their chronic kidney disease, as it's another hit to the kidneys. And finally, there is also a risk of death, probably mainly as a result of all of the above and the underlying cause of the AKI itself that contribute to that. Okay, so now moving on to the principles of management. So I keep going on about the fluid status, but it's very important in kind of how you manage the AKI. So if you think someone has got an AKI because they are dehydrated, or there's hypovolemia, maybe secondary to sepsis, or for example, you don't want to rehydrate them with IV fluids. But sometimes patients who come in overloaded might develop an AKI as well. So sometimes you then see improvement using diuretics once you start offloading the patient. So that's why it's important to figure out what is their true fluid status. You then want to review their medications. So you don't want to hold medications that might worsen the condition to the AKI. So that's NSAIDs like ibuprofen or ACE inhibitors. And then there's some medications that you might hold or just adjust, so reduce the dose because they might accumulate rather than contribute to the AKI, but they just might not be excreted as well as before. So that's things like metformin and certain opiates. If you're worried that someone's got an obstruction, the best way to treat it would be to relieve that obstruction. So whether that's getting rid of the kidney stone or bypassing the prostate temporarily with a catheter. And then finally, if you're thinking it's due to an infection, treat the infection. Okay, so now I'll briefly touch on patients that might need hospital admission. So if someone's got a stage 3 AKI, then you'd want to refer them to a hospital because that's quite a severe AKI. If there's an underlying cause that requires admission, so if it's a severe obstruction or an infection, they will have to come in irrelevant of their AKI if that itself warrants the admission. If you can't find an obvious cause and it's quite a bad AKI, they might come in either to for an admission or for a hospital review, like an ambulatory care unit. If there's a risk of obstruction that needs to be treated, and you might consider bringing them in. Sepsis, naturally, any hypovolemia that requires IV fluids, so that can't be managed with oral intake. If you've been trying to manage the patient in the community, for example, but they start to deteriorate and need some closer monitoring, you'd consider referring them. Or if you suspect that there's a complication of the AKI, so encephalopathy, pericarditis, or severe hyperkalemia, you would send them into hospital for assessment and monitoring. So when would you discuss with renal? And in this case, it'd be within 24 hours, so it's very urgent. So if someone's known stage 4 or stage 5 CKD, you'd want to discuss it with them because they've already got quite poor baseline renal function. If you're worried about one of the kind of specialist diagnoses, so tubular interstitial nephritis, glomerulonephritis, and systemic vasculitis, where you need that specialist input, you discuss with renal. If, again, you've tried to treat it in primary care and there's no response, then you consider discussing with nephrology or renal. And if someone's got a renal transplant, so once someone's had a renal transplant, the renal team like to follow them up and keep a close eye on them, and especially if they develop AKIs, so they'll be quite heavily involved in the ongoing management of patients who have had a renal transplant. Okay, so now for people who have stage 2 AKIs, so that's I guess moderate AKIs, could be managed in the community, But if you're not sure, or someone's not sure, the GP or the community aren't sure, you can consider discussing those with medics or the renal team. So that's according to the NICE guidelines. Individuals stage 1 AKI do not necessarily require admission or even referral of specialists. They can be managed in the community. So then it goes back to the kind of principles of managing the underlying cause, supportive measurements, oral intake, things like that. Consider temporarily stopping the medications that I mentioned, so ACE inhibitors, ibuprofen, things like that, and kind of reviewing them regularly to see whether they can be reintroduced. Monitor the creatinine to make sure it's trending in the right direction, and obviously keeping a close eye on people, and if things change, to kind of revert back to the previous management points and consider admission if anything changes. So and now another thing, dialysis. So renal replacement therapy can be considered in very severe AKIs, and these are the kind of main reasons why you would consider dialysis. So one is refractory hyperkalemia. So refractory after you've tried to bring down potassium using your medical management, if it still remains high, you'd consider dialysis to try to get rid of that excess potassium. If someone's got pulmonary edema that is refractory to medical management, so offloading doesn't help, and they keep, they stay on oxygen, they've got respiratory failure, you'd consider dialysis to get off that excess fluid. If someone's got complications of uremia, you'd consider dialysis. Okay, so things like if they've got encephalopathy, apologies, you might consider that. Severe acidosis, you would try to correct the electrolytes and correct the pH. And if there's any toxins that you might be able to, take out using dialysis, that might be considered. Okay, so that's in very severe cases. So that was a quick whistle-stop tour through acute kidney injuries. I've just got a couple of questions to check your knowledge, or if you've learned anything from the previous few slides. So the first question is, 75-year-old Mary presents to A&E following an unwitnessed fall. She was found by her carers in the morning, having last been seen the evening before. So routine bloods done, so full blood count, renal profile and CRP, been sent. She's found to have AKI stage 3 in her blood results. Which further blood test would you send for in this case? Would you send for magnesium, creatine kinase, D-dimer, blood glucose, or BMP? Okay, so the answer is creatine kinase. So Mary's been found on the floor, and we're not exactly sure how long she's been there. So she might have been there for quite a while. She's got a significant AKI, so it's important to know whether she might have rhabdomyolysis, and that's the marker for that would be creatine kinase. Okay, so that's why you'd want to send that. In this case, okay, BMP would be to look for any signs of heart failure. She doesn't seem to, the brief hasn't mentioned that specifically. Magnesium could be relevant, but it's the main thing we're concerned about at the moment is a rhabdomyolysis. Okay. Question 2. 50-year-old John attends the GP for routine bloods. He has a background of diabetes, hypertension, hypercholesterolemia, for which he takes metformin, ramipril, and atorvastatin. He has recently started taking regular ibuprofen due to pains in his knees. His bloods come back. Which medications would you consider stopping? So his blood tests are over there. So sodium of 138, potassium 4.7, then creatinine 135, and an EGFR of 51. So would you consider stopping just the ibuprofen, the metformin and the atorvastatin, the ramipril and the ibuprofen and ramipril, or metformin, ramipril and ibuprofen? So the correct answer here is E, metformin, ramipril and ibuprofen. So you'd want to hold the ramipril and the ibuprofen definitely, because they are called there are drugs that might cause the AKI itself, and you'd consider stopping the metformin as that can accumulate in AKIs. You don't always hold it, but it's a clinical judgment, and it can always be reinstated once the AKI has resolved. Okay, now moving on to chronic kidney disease, or CKD for short. So the aims of this talk are very similar to the one previously. So understand what chronic kidney disease is, what the definition is, understand the main causes, learn about the diagnosis and presentation of CKD, and then understand the management as well. And like before, we'll have a couple of SBAs at the end. So what is the definition of chronic kidney disease? So in comparison to AKI, it's a long-standing change in someone's renal function. Long-standing in CKD is considered to be more than 3 months, okay, of a change in someone's renal functions and subsequent implications on their health. The cutoff that is used is an eGFR of less than 60. And the presence of kidney damage can be seen by either albuminuria, so an albumin creatinine ratio of more than 3 milligrams per millimole is usually the cutoff. Whether there's anything like urine sediments, so casts or white blood cells, any hematuria, any structural abnormalities, or if someone's got a transplant. And in CKD, there's also something that's called accelerated progression. So that's defined as a persistent decrease in eGFR of 25% or more, and a change in CKD category within 12 months, or a persistent decrease in eGFR of 15 within 12 months. Okay, so that's a separate group. That's a more severe, quicker progression of CKD. So CKD is classified using this diagram, and it's based on kidney function using eGFR and kidney damage based on albuminuria. So you've got the different stages from technically 1 to 5. So that's grade 1, kidney function. G1 is normal or high, so it's above 90. You've got mild decrease, which isn't really CKD yet, which is 60 to 89. And then you've got kind of progressively it gets worse. You've then got the albumin, which gets divided based on 3 ranges, so less than 30, 30 to 300, or more than 300. As you can see, based on the combination of those two, you've got low risk, moderate risk, high risk, or very high risk of complications. So there are many causes, as you can see on this list, of CKD. The most common ones that I've highlighted here are hypertension and diabetes. So those are the ones that are most often seen, but it can be due to obstructions, so chronic obstruction. If people, like I mentioned earlier, if they've had AKIs in the past, someone's got a hereditary condition like polycystic kidney disease or Alport syndrome, that puts them at risk of CKD. Well, at risk, it causes CKD. Infections, severe infections can cause it. Continuous drug and substance toxicity, and then things, very specialist things like lupus nephritis, glomerulonephritis, autoimmune diseases, hemolytic uremic syndrome, vasculitis, renal artery stenosis, myeloma, gout, and obesity with metabolic syndrome. So many causes to be aware of if someone has CKD. Okay, and what are the symptoms and signs that you might have? So most people will be asymptomatic. Many don't even know they've got it and it doesn't impact their daily life. But you can have quite a range of symptoms with it. So you might have fluid overload, so that's peripheral edema or pulmonary edema. They might be dehydrated clinically. They might develop high blood pressure or have high blood pressure. Generally, they might have flank masses, so enlarged kidneys, hematuria or frothy urine. They might notice poor sleep and restless legs, cognitive impairment. So uremic, the kind of symptoms of uremic toxins, so fatigue, anorexia, nausea, vomiting, itch, and then, signs of pericarditis and encephalopathy. They're at risk of developing things like neuropathy and pains due to bone disease. And the symptoms of anemia, so complication of CKD is anemia, so things like fatigue, shortness of breath, and pallor. And investigation. So how would you go about investigating? So you do bloods to check renal function, creatinine, EGFR, do a full blood count, electrolytes, so full blood count looking for any signs of anemia, do a urine dip, check for proteinuria, hematuria. You'd want to do early morning urine, albumin creatinine ratio. That gives you that proper holistic view. The both sides, the EGFR and the albumin side of that graph chart that I showed earlier. It's important to repeat the bloods within 3 months, and that's because the definition of it is long-standing, so at least more than 3 months. So you can't just diagnose CKD based off one reading. You do need to have that chronic change. You'd want to look for risk factors, so you do a baseline HbA1c, check the lipids, check their blood pressure, whether any of that needs optimization. And NICE guidelines suggest an ultrasound in adults if they've got rapid progression, they've got very visible or persistent invisible hematuria, they've got a positive family history of polycystic kidney disease, and they're over 20. If they've got an EGFR of less than 30, so grade 4 or 5, and you'd refer them to a nephrologist if they feel they need a renal biopsy. So not all patients with CKD will get a renal biopsy. It's only in specialist cases. So complications, I've touched on a few of them already, but there are many complications of CKD. So, if someone's got CKD, like I mentioned earlier, they're at risk of developing an AKI. Having CKD might be due to hypertension, but if there's if the kidneys are damaged, that itself might cause hypertension. They'll have dyslipidemias. They're at increased risk of cardiovascular disease, so that's things like ischemic heart disease, heart failure, or stroke, renal anemia, and that's due to reduced erythropoietin, which usually stimulates red cells. So that's produced by the kidneys. So if you have less of that, you've got less red cell stimulated, and you'd see a normocytic, normochromic anemia. And you could get renal mineral and bone disease. So you'd tend to get you could get high phosphate, and that's due to reduced excretion of the phosphate from the kidneys, and low calcium and low vitamin D activity. So bone disorders, you could get osteomalacia, and that's because of an increased turnover to kind of increase that calcium supply that you've got, which is low already. Malnutrition, peripheral neuropathy and myopathy you can get as well, risks of malignancy, end-stage renal disease, so that's the kind of progression of CKD. And interestingly, they've people with CKD have a general increased risk of all-cause mortality. So how do you manage it? So the main aim or target in CKD is to prevent progression of the disease. And you'd go about doing that with lifestyle changes. So if someone's got diabetes or high blood pressure, to change the diet, to exercise, to keep that under control. You'd monitor their blood tests regularly to check for progression, make sure that the renal function is stable. You'd try to, so medications wise, you'd try to modify the causes or, control the causes. So for hypertension, you'd give antihypertensives, or if they're diabetic, to make sure they've got good control. So need metformin or others, or even insulin, things like that. And then you can give specific medications for CKD as well. So that's ACE inhibitors and SGLT2 inhibitors. So ACE inhibitors are offered to all patients who have diabetes and a urine albumin creatinine ratio more than 3 milligrams per millimole. You'd offer it to patients who have hypertension plus a urine albumin creatinine ratio more than 30, and all patients who have a urinary albumin creatinine ratio more than 70 milligrams per millimole. If you start someone on ACE inhibitors, the potassium needs to be monitored very closely because there's a risk of high potassium in CKD, hyperkalemia, and ACE inhibitors itself can cause hyperkalemia. So that's just something to bear in mind. SGLT2 inhibitors, so that's something like dapagliflozin, they are licensed for CKD. They're given to individuals who have diabetes and a urine albumin creatinine ratio more than 30. You can consider it in patients who've got diabetes and a urine albumin creatinine ratio of 3 to 30, apologies, or someone who's not got diabetes and they've got a albumin creatinine ratio of 22.6 or above. Okay, so those are the two kind of main medications that are used in patients with CKD specifically. You'd also want to look at managing the complications and the risks associated with CKD that I've just mentioned. So antiplatelets, preventing cardiovascular disease, statins to control their lipids. If someone's got anemia, you consider erythropoietin or iron if it's not an EPO issue. Sodium bicarbonate could be considered. Vitamin D, phosphate binders for those renal electrolyte disturbances. So NICE suggests that patients who, or recommend really, that patients who've got CKD are offered immunisation. So that's specifically the influenza and pneumococcal vaccines because they're more at risk of severe complications from those two. Dialysis should be considered as well in patients with CKD. So that's mainly if they've got symptomatic burdens, such as cognitive changes, which are like related to the CKD. If they've got metabolic disturbances refractory to medical treatment. So again, that is like in AKI, but patients who like slowly, start developing hyperkalemia that's resistant to any of the medications that we can offer them, or if they have fluid overload refractory to medical treatment. So similar kind of indications to those with AKI, and you'd also consider it in kind of end stage renal failure because the kidneys are not working really at all. Kidney transplants are an option. They're not very commonly used, but they are an option, and that'd be at the discretion of the renal kind of team. Right. When would you refer someone with CKD? So it's kind of from the GP point of view mainly. So that's to be a 2-week wait in someone who's got persistent hematuria and you're concerned that they've got a urological malignancy. You'd consider referring someone to renal if they've got a 5-year risk of needing renal replacement therapy or dialysis, which is more than 5%. If they've got an EGFR of less than 30, if they've got accelerated disease, so that was like I mentioned at the very beginning, that's if they've got very rapid deterioration in their renal function. If they've got an albumin creatinine ratio more 50 or more, unless they've got associated diabetes, if they've got a ratio 30 or more, and they've got persistent hematuria, you'd refer them unless that is due to a UTI. So you need to rule that out first. Patients who've got persistent hypertension despite 4 types of antihypertensives, if you're worried about a genetic cause of their CKD, renal artery stenosis is one of your top differentials, and if they've got any of the complications of CKD. And then you'd refer to urology rather than renal if you think obstruction might be the cause of their CKD. Okay, so that was kind of, again, a quick whistle-stop tour through CKD. So just got a few questions on CKD. So there's a 50-year-old Michael presents to the GP for repeat bloods, and he's found to have CKD. So he's had his first set and he's now come back for his second. Past medical history, he's got diabetes, rheumatoid arthritis, asthma and anxiety. Which of his conditions are likely to be the main underlying cause of his CKD? Is it rheumatoid arthritis, asthma, diabetes, anxiety, or all of the above? So the answer is diabetes. Okay, so that's, like I mentioned, one of the two top ones, hypertension and diabetes, are the main causes of CKD. Okay, question 2. 70-year-old Janice presents to A&E feeling short of breath. She has a background of CKD, diabetes, hypertension, and osteoarthritis. You do a set of bloods and a VBG. Which feature is most concerning? Is it potassium of 5.1, an eGFR of 18.2, creatinine of 230, a pH of 7.42, or is it an oxygen requirement refractory to medical management? So yeah, it's E, oxygen requirement refractory to medical management. So she's got significant overload and that can't be shifted. So this might be someone that would be considered for urgent dialysis. Okay. So question 3. 65-year-old John presents to the GP with known CKD. His past medical history includes diabetes, hypertension, and COPD. His eGFR is 47 and his urine albumin creatinine ratio is 17. Which of the combination of medications would you expect him to be on or started on? I think ramipril and atorvastatin, torvastatin and dapagliflozin, ramipril and dapagliflozin, torvastatin only, and ramipril only. Out of these ones, which is the correct answer? It's a bit tricky, but the correct answer here would be ramipril and atorvastatin. So he would definitely be starting on those. So atorvastatin for primary prevention, and ramipril as he has got diabetes and a urine ACR more than 3. You would consider dapagliflozin in diabetes and urine ACR between 3 and 30 as well. Okay, but so that's the answer there. Okay, so thank you very much for listening to this talk. So if you could please fill in this feedback form to get access to the slide once you submit. So even if you're watching this on YouTube, if you just scan that QR code. Thank you very much. And these, like I mentioned at the start, these are the slides, the resources that I use. These are the AKI and these are for CKD, if you'd like to go and read a bit more about it for your revision. Okay, I'll just go back to the QR code slide.